Okay, hello everyone. Thank you for joining us today for the second episode of our Pearls monthly lecture series for 2025. For those who are new here, Pearls stand for POCUS for Emergency and Acute Care in Resource Limited Settings. We're a non-profit organization entirely run by volunteers, and we aim to provide free POCUS training to doctors around the world. Due to some unforeseen circumstances, Dr. Warren Addy is not able to deliver his lecture as planned today. However, we are very fortunate to have Dr. Matt Bourne, who has stepped in to save the day. Dr. Matt Bourne is a rural hospital consultant based at Dunstan Hospital in South Island of New Zealand, and he's also a teaching faculty member at Otago University as well. He has been a staple teaching faculty for Pearls for many years and has been a passionate volunteer for many medical missions abroad. Today, Matt will be presenting on the topic of abdominal POCUS in rural and resource limited settings. And at the end of the presentation, you will also have the opportunity to ask Matt questions as well. So, Matt, please take it away.
Yeah, thank you, Long. Yeah, thank you very much. Thank you very much for the invite. Yeah, this talk is very much different from the one that was advertised. Like Long was saying, I come from the South Island of New Zealand, and this is a picture of our tallest mountain, Mount Cook, where Sir Edmund Hillary practiced his climbing before he then went on to the Himalayas to conquer Everest. And I'm a rural hospital consultant. So I work in central Otago. This is my town, Alexandra. This has a population of 4,000, but our hospital has a catchment area that's quite broad, and we have about 30,000 or so who feed into that hospital. And it's a growing population because it's a pretty nice place to live. And a lot of people also come during the different seasons for skiing in the winter and walking in the summer, etc. And so, with various events that go on, the population can double and treble in time. So this is just a view of the inside of the ward. It's in the early hours of the morning. Doesn't look very busy, but we normally have somewhere between 70 to 100% occupancy. But it is a small rural hospital, and I'm talking today about working in rural and resource limited settings. Now, this is a picture that's outside my house, and you can see the mountains in the distance. And this is what we may see in the winter. So the winter can produce the hoarfrost here, and we can be within the inversion layer of the cloud, and can be quite isolating. And our tertiary referral centre is 2.5 hours away. And because of that, all the rural consultants at Dunstan and a lot of the registrars have learned POCUS pretty early on. And the reason being is that we found it a huge advantage for us because we don't have access to all the necessary imaging at the moment. We've just got one ultrasound day a week. And when I first started at Dunstan, we just had X-ray and a little bit of ultrasounding. Now we actually do have a CT scanner. But in the New Zealand state of affairs, we are a low resource area. And I do appreciate that there's a very big difference between what might be low resource here and what might be low resource in the Pacific, for instance. So just to tell you a little bit about myself, thank you altogether, long Eufla come long Papua New Guinea. Now, some time before me been stapled on Papua New Guinea, time me young fella yet. So just saying hello to the PNG group, and I know this is many of the watchers of this webinar from the islands. And when I was a young doctor, I spent 18 months or so in Papua New Guinea. Subsequent to that, I've been to Vanuatu several times to do with water projects and also with a little bit of teaching there. Not last year, the previous year, I went to the Gambia in West Africa and I spent several months there involved with work and teaching. mainly with ultrasound. And then at the end of last year, I spent some time actually in Nepal, first of all, for a month, and then in Malawi for a couple of months, where I also was involved with some teaching and providing, I guess, a bit of ultrasound service. And this is very much a limited resource setting. And this is in Blantyre, Malawi, Queen's Hospital. So this is just a general slide about POCUS overall. It's all the things that you know of, and the reason why we are holding these webinars is we recognise the value that ultrasound is in the hands of doctors. And just to reiterate that point, that we're not referring to a sonographer who gets very little history, and doesn't know, doesn't have the benefit of the examination and necessarily the other tests that we have as well. And using ultrasound together with our history examination and other forms of imaging, perhaps, to help us form diagnoses in patients and initiate their management or improve the accuracy of our procedures. So, and that's very much what this talk is about, really, because I'm giving a talk about POCUS of the abdomen, and mainly to do with pain, somebody who might present with pain in the abdomen or present with distension of the abdomen. That's a huge topic, and this is by no means going to cover all of it. I will try and throw in lots of ultrasound scans and tell lots of stories. But there are some things that we learn, of course, and the courses that we do, and we follow certain algorithms, such as we might use the FAST exam and the FASH exam, and we learn about how to examine for the gallbladder and the kidney, etc., etc. We use all those skills together, but when you're actually doing an abdominal ultrasound, remember it's in the addition to what your the history and examination you've taken. And your findings may depend on the context of which you're working, whether it be somewhere like New Zealand or somewhere in the tropics and the range of diseases that may be present. And also it will depend, whether the person is male or female, their age group that they're in, whether the woman is pregnant or not, and all these sort of things. So it all matters, and this isn't a webinar to give you an algorithm to follow, but just to show you the sort of things that I get up to as a rural consultant, and what I've seen as well in my experiences in the tropics. So let's start off with something very basic. In Central Otago, we have a very large elderly population, and we have lots of men who have benign prostatic hypertrophy. And it's not an uncommon presentation for someone to present with abdominal pain and not being able to pass any urine. And ultrasound loves fluid in the body, and you're probably very used to one of the earliest scans we might do is we might scan various cystic structures, and the bladder is probably one of the biggest fluid-containing structures that there are, and we can make some determination about whether this person is in retention or not, and then pass a catheter and relieve that. And you may say, well, Matt, why are we even talking about this? This is a sort of a fairly sort of boring, uninteresting thing to be talking about. First of all, well, take this case here. This is a woman who was referred to me, an elderly woman who was referred in retention, had a catheter passed. It was quite difficult to pass apparently, and they actually ended up with some hemorrhage per urethra. And they couldn't get any urine out, and they referred this lady to me and said, hey, Matt, look, we think we may have created a false passage. What's going on? And I'm sure you can see with this image, it's not the same as the previous one. There isn't an anechoic cystic structure here. And the actual story was that this lady was actually dry. She had actually spent the previous day in the sun. She hadn't been drinking that much, hadn't passed urine at all because she was dry. And indeed, she was actually tachycardic and underfilled. But they palpated a bladder, and the emphasis here is that, just remember the number of times that sometimes our hands can betray us, and this person was thought to have a bladder, but just had a big abdomen, and didn't have, weren't in retention at all, and that led to, unfortunately, some trauma from trying to pass a catheter. So in the urinary sort of area theme, let's go on to look at some hydronephrosis. So we very commonly in New Zealand and very commonly around the world, we get many presentations of people who present with renal angle pain. And again, one of the earlier scans that we often tend to learn is to look at the kidney. And here we have the kidney on the left-hand side here. And we can see they've got quite a big cortex here, which is good. But you can see that anechoic area of the collecting system here. And we shouldn't be seeing it as dilated as this. And of course, this is dilated because it's suggesting there's an obstruction more distal to this. And we saw the longitudinal view, and this here is the transverse view, and you can see that that ureter that's dilated. And we may go, well, we would always look at the bladder, but we may be lucky enough to see where the obstruction is. And this is a common cause of obstruction. In the vast majority of cases, we can actually see a hyperechoic stone sitting there. And if you've got these on your machines, you can actually put color on that. And sometimes you can get what they call a twinkle artifact. So this is someone where we've made the diagnosis, made it under POCUS. In my setting here, there's a number of people that actually often have early CT scans, but if we make the diagnosis with ultrasound, or if you don't have a CT available, then you don't need to irradiate people. The more you irradiate people, the more adverse outcomes there can be as they count up the amount of times they're irradiated in their life. We must always remember the group that may present with renal angle pain in our elderly age group, and sometimes it can present like this. But again, in New Zealand, we commonly have people who present with abdominal aortic accidents, and this is a very old scan now. This is someone who presented with a dilated aorta in their abdomen in the context of coming in with quite severe abdominal pain radiating through to their back. And we normally have the limits of allowing for sort of 3 centimeters swelling in the aorta, and this one is clearly bigger than that. And again, I do appreciate, and it will depend on where you work, on the way that you might manage this. But this is a lady who had good quality of life, and she wanted to have treatment, and she was transferred to our tertiary center. And she went on to have a stent inserted. And here we can have to see the transverse view of her aorta. And this is the stent, an EVAR it is, it's called. It's placed inside of the aortic cavity. And this worked very well, and she was sent home, and she was absolutely fine for the next 3 years. And then she re-presented to the hospital again. And she presented again with some abdominal pain, and she was somewhat shocked as well, and this pain radiated to her back. And I'm sure you can tell with the sort of I'm putting the color Doppler on this. So remember, this is her stent. This is the outside. This is the aneurysm. And here we've got flow going between the two. And this was a failure of that stent. We had a good discussion about this. Here's the aneurysm again. And there's the flow. She elected to have no further treatment at that point. Again, one of the common things that I might see in New Zealand are people who present with right upper quadrant or with epigastric pains. And again, together with my history and examination, often from the history as to whether they have a fever or not, on examination, are they jaundice or not? Do they have an ultrasonographic Murphy's, a palpable Murphy's sign? And of course, gallbladder disease forms an important part of the differential. So let's go through a few of the things that you might see here. And this is a longitudinal view of the gallbladder. And we can see that this is their portal vein. This is the view of the gallbladder. You can see a beautiful stone sitting here with a shadow coming from that stone. And you can also see another stone here. So this is someone who presented with acute cholecystitis. And I was able, with those images, to refer this person on to our surgeons in our tertiary center. This is another gallbladder case where someone who presented with biliary colic. We often put the probe, as say, over where the gallbladder is and see if they've got an ultrasonographic Murphy sign. And often you find they're more tender if you know that the gallbladder is directly below your probe. And there might be more tender here as opposed to more of the epigastric midline area. But this is someone who had some biliary colic and the symptoms actually settled down. They had normal blood tests. They had no raised bilirubin. And you can see the stone again. This is with a different scanner from the previous one. Here's the stone and here's the shadow cast by that stone because the ultrasound waves don't pass through the density of that stone. This is somebody I was able to stand up. And as I stood them up, can you see that stone beautifully moving away from the neck of the gallbladder? And so this is someone with biliary colic. So again, that stone formed a more ball valve effect. After them having a fatty meal, it obstructed, causes pain, and then it was relieved thereafter. This can be quite important to know, and it may help the surgeon decide as to when might be the best time for this person to have a gallbladder removed, rather than necessarily be absolutely acutely urgently. It could be delayed, depending on what service you have. And again, just continuing with that right upper quadrant pain theme and gallstones. This is another patient. And we can see here, so we've got a transverse view of their gallbladder. We've got some very small stones here. And those are the size of the stones that you may actually worry about, because those stones, they can escape from the gallbladder and get through the neck. And here I'm going to the longitudinal view. I'm going through the whole of the borders, boundaries, and beyond that Joe might talk about. I can also see some dilated tubes here to one side. Now, if I focus in on those tubes, we almost get the classical view here. So this is a patient lying on their left side, and I've got the marker pointing towards their right shoulder. And here we have, this is actually their portal vein. And this is the bile ducts. And here we see the round hepatic artery line between the two in a so-called sandwich. And though I don't tend to always use color Doppler because it can be confusing, in this case, you can see that there is flow through the portal vein and the hepatic artery, but no flow through the biliary duct. And I can measure that. And once we start to get sizes of the biliary duct that's greater than 6 millimeters, as this is, then we're thinking this is highly significant in a person who hasn't had that duct explored for any surgical reason before. And I can even follow sometimes the duct if I'm lucky. I can see a more proximal end. And then to my luck, I can also actually trace this one into the where the pancreas is. And indeed, this person actually had a gallstone pancreatitis. Let's talk about those who might also present with pain perhaps in their upper abdomen. Hepatosplenomegaly has a great range of differential diagnosis, and the differentials will be very much different in New Zealand, my country, where I mainly practice, compared with the Gambia, Malawi, or in the Pacific Islands. So this is a person, this is actually from Malawi, and they have a quite a uniform looking liver here. They don't really have too many tortuous vessels, don't have a great number of hepatic dilatation there at all, but it's a big liver. I'm looking through it on that side. And then when I go to the other side, I see they also have a big spleen, and both those organs can be palpated. The spleen I generally look at rather than necessarily measuring it. It's usually finishes about halfway along the kidney, and this one's very much extended down their abdomen, this being the head end, of course, of the patient. So differential diagnosis, as I said, will depend on where you work in the context that you're working. So in New Zealand, it would be uncommon for a first presentation to me, but I might think of a myeloproliferative type disorder, potentially having lymphoma or leukemia. And indeed, that can be a differential in sub-Saharan Africa, as those can be secondary to having more chronic infectious diseases. But also, again, in your context, you may think of someone who's got a chronic hepatic disease and has got secondary portal hypertension, which leads therefore to an enlarged spleen. Tropical diseases, again, if you're in the right country, you might think of leishmaniasis. And of course, we mustn't forget diseases such as malaria and chronic infections with malaria. Um, and not necessarily these sorts of sizes, but also we can think of acute hepatitis illnesses that can cause problems, and then the chronic sequelae of having hepatitis B and beyond. Pyogenic liver abscess. So sticking, I guess, with the right upper quadrant. This is a patient who actually presented to my small rural hospital, but they actually came from the Philippines. And this is someone who had a fever, right upper quadrant pain, and they were tender on palpation. I think they're about in their 40s or so. And here we can see this hypoechoic cystic area that's quite irregular. And as I pass through the liver, you see it's actually quite bright there. And I think those are dilated hepatic ducts. But it's quite irregular. You can see also along the I think it's again the portal triad. It almost looks quite bright along those areas there. This is someone I was able to refer on to our tertiary center to the surgeons. They did a needle aspiration of that and found that they had a pyogenic abscess. I think it turned out to be a Klebsiella in the end. This is from the Gambia context, but it could equally apply to any of in any country in sub-Saharan Africa and in the Pacific, in the tropics. This is someone who presented again with a fever and right upper quadrant pain and a tender liver. And although more commonly, I think that we describe sort of more uniform ovoid sort of cystic abscesses. This one is a bit of a multiloculated one. And you can see there's the liver. You can actually see that there's some ascites or fluid around the liver here. This is the kidney. And this is the abscess that we're looking at, a bit more heterogeneous and multiloculated. Now this is me putting some power Doppler over it just to see whether it's got a blood supply, because there's a bit of a differential of what this might be. And I was certainly thinking it may have been malignancy. But this is someone who ended up on a course of metronidazole. It wasn't actually aspirated. There was concerns about seeding the amoeba, and they were treated with metronidazole for a couple of weeks, and this shrank down. I don't actually have the subsequent images, and they got better just by having the antimicrobial treatment. Okay, so we spoke about possible differentials of what you might find in the liver. And this is another case. I think this one is from New Zealand. And most malignancies that we may pick up in the liver in New Zealand would tend to be secondaries. So this is someone who, we're looking at the liver tip here, and it's perhaps looking a little bit an unusual shape. This is the gallbladder. This is the portal vein. And you can see here, hopefully it translates across to you on Zoom, but there are rounded hypoechoic multiple lesions here. And this is someone who's got metastases that have gone to the liver. I think this was actually an original bowel cancer. Now in New Zealand, cirrhosis of the liver, the most common cause of this will be alcohol as a toxin. But it could be very different in your circumstances from my colleagues that might be working in the Pacific or again in sub-Saharan Africa and such like. It may depend on the vaccination status and the age that people might have or are receiving vaccination for hepatitis B, because that'll be the most common reason for having cirrhosis that I found that was present in the Gambia and in Malawi as well. Here I'm using the butterfly scanner, and you can see the liver here with its irregular edge. It's actually got quite coarse architecture as well. And you can see the free fluid, the ascites around it, and this is the bowel that we're seeing here. And this was a very common finding in both the Gambia and in Malawi. Both of them, particularly if the person was under the age of 30, 35, because it was only more recently they started having their hepatitis B vaccinations. This is another case. This is from Malawi. And it's important to put across here. I was working in the emergency department. We didn't necessarily have all the blood tests available to us. There are days where we had no biochemistry. There are days where we had no full blood counts. The access to further imaging was very variable. It may depend on whether someone could pay for it or not. And so I don't have necessarily the exact diagnoses, just my strong suspicions of some of these patients. So we can see that this liver looks unusual. We can see as well around the liver, there's some, if I can get my marker, there we are. You can see that there's hypoechoic area around the liver, and there's complex ascites around it. And there's quite a lot of sort of fibrotic scarring there. And here I'm in Malawi. You have to remember that Malawi is very famous for its lake. And they've still got schistosomiasis in that lake, although there have been great programs to eradicate that. But there are many people that might have had schistosomiasis when they were young, and it's not been diagnosed, and it's led to them having cirrhosis of the liver and ending up with this type of more fibrotic type of appearance. And then if I look on the left-hand side, it'd be very common for them to develop aspects of portal hypertension, and thus they would have enlargements of their spleen. And this is an enlarged spleen again, descending right down into their abdomen. And you can see again the free fluid that's surrounding this. So again, sort of a progression of how we might, things might present from the liver perspective. So there are a number of patients who may have chronic hepatitis B that might go on to have fibrosis and cirrhosis, but there will also be not an insignificant number that unfortunately may go on to have hepatocellular carcinoma. And actually, this was a person in the Gambia, I believe. This is again the butterfly scanner, and you can see that we're getting some pictures here of the liver, the ascites-free fluid. This is the kidney, and look at that heterogeneous liver there that was causing quite a lot of pain. And it may depend on the context of where you work and whether there's any treatments available. But from the Gambia perspective, there was very little we could do with patients like this. There was from people who had any form of malignancy, there was no form of radiation within the country, and extraordinarily limited chemotherapy. This patient was treated palliatively. So thinking about patients who may present with abdominal swelling and again ascites, you're trying to work out what's going on with them. And if they're presenting to you, you might be the only doctor within your setting, in your rural hospital or in your clinic, or indeed in a tertiary hospital. And this is an emergency department in Malawi. Here we can see that rounded, that's the dome of the diaphragm, so we are below the diaphragm. This is ascites, and I think this is the liver that we're seeing. As you see the spine come up there in view for a short period of time. So they've got ascites, and further on views, here's the ascites. We've got some fibrin strands that are here. We've got a very second area here, and I wasn't quite certain as to what this was. And then I've got this heterogeneous area here, and I start to sort of examine further down in the abdomen, and I've got this again very heterogeneous area. Looks like it's forming sort of an enclosed cystic area, and I'm highly suspicious that this is a malignancy. What I'm not sure is it's a 64-year-old female, as to whether this may be arising from from their ovary or indeed from the bowel, etc. Ideally, they would need to go on and have further, better imaging studies, but as they were referred on to the appropriate specialist service they needed to. And talking about cystic masses, this is another lady. This is a 40-year-old. And here we can see again the diaphragm. We're on the left-hand side. This is the spleen. This is the kidney. And as you may remember, that fluid would tend to collect between the diaphragm and the spleen on the left-hand side, and we can see that illustrated here. And as I move further down into the abdomen, I can see there's some sort of fibrin floating around with some fluid. And I've got this, again, this encapsulated area, and I've got this sort of this collection here, which is fluid, but with floating substances within the fluid. And then as I then explore further down, I've got this big cystic area here, and I've got this big cystic area here. I don't think they're in bowel obstruction. I'm thinking this is more actually, again, this is a cystic collection, and it's probably arising from the ovary. And ultrasound has only shown me a certain part, but it's helping me decide the disposition of this patient and which service I might refer them to, but they would clearly need further studies done. Again, this is important, and it's important to stress to you that rather than necessarily me saying that this should fall within the remit of what you should be doing for your scanning, inevitably from where you're working, as you scan the abdomen, you'll recognize a normal anatomy. When you find the anatomy isn't normal, then that then leads you to do something about it, not just dismiss it. And you can have your suspicions of what it might be, and hopefully there are ways and means in your country to refer to someone who may have the skills to do that. Actually, haven't had these films reviewed by somebody else. I probably should get Jo to have a look, and she may indeed be online today. This is someone who had a pain and swelling in their abdomen. And as I'm scanning through them, I'm thinking, well, I'm seeing the liver up here, and I'm thinking this is their kidney to one side here, and this is their collecting system, but I've also got this area here that just doesn't look right. And I'm thinking this is, again, a heterogeneous mass that seems to arise possibly from the way it's separated from the liver. Maybe it's arising from the kidney. And in my mind, I'm wondering whether actually this is a potential renal cell carcinoma. But I know that the anatomy is wrong, and this needs further investigation, again, ideally in the right context, to go on to have a CT scan and refer to the correct services. And what is quite unusual about this case, if I'm going across to the other side, I can see her spleen up here. But again, I've got something that does not look like a normal kidney here. And indeed, as I sort of fan through it, I'm thinking, goodness, have they got a kidney and something arising from that kidney from the other side? Bilateral renal cellular carcinoma is uncommon. It can happen. The literature does describe it, but I'm wondering whether that may be the case here. I put some power Doppler over that to try and see as to whether the blood supply may be increased and whether that more likely would happen with a malignancy. So thinking about the abdomen, again, more this is a case actually from New Zealand context. We have a lot of patients who've had previous surgery and present with subacute bowel obstruction. So these are people who have had previous surgery, develop adhesions. They come in with swollen, painful abdomen. And here we can see the small bowel. You can see the dilated loops of bowel, greater than 3 centimeters. We can see the peristalsis taking place. It's a tubular structure. There's a bit of fluid outside. And we can see the plica circularis going all the way across, or the valvular componentes, as I don't know what you want to call them. And if I go to the next slide, we can see that they've actually got reverse peristalsis. If you see, peristalsis goes one way and then the other way. So for some cases of subacute bowel obstruction, I might sit on my hands in my rural hospital and see if they will give the bowel rest and give them IV fluids and see if they will spontaneously start to flow start to go the right way. And after a period of time, if that doesn't work, then I also might go on to do a CT scan and refer them on to my colleagues in the tertiary centre. This is, I guess, not strictly from the abdomen as such. They did have a pain in the lower left-hand side of their abdomen, but they had quite an obvious swelling in their scrotum. So this is someone from Malawi who has got the swelling in their scrotum, and we can see a cystic structure within. there's some contents there. And indeed, this is the scrotum, and we can see that there's a couple of transverse view of bowel that we're seeing here. And now we're in quite excruciating pain. And I think that the bowel wall is probably thickened, and I can't see peristalsis there so much. I can see some contents in the bowel here. And this led me to refer this slightly on and need to have urgent surgery for strangulation. And what I would call would be definitely a rule-in diagnosis. So thinking about, again, our younger patients, this is a younger, well, they can present at any age, of course, but this was a young patient who presented with pain in their left iliac fossa. And rule in, I mean, I really struggle to diagnose and find the appendix and diagnose appendicitis. But every now and then, every now and then, you might get someone who is able to put their finger on their most exquisite point of pain. And here I have that rounded structure, that cardiac structure there in the middle, where you can see the abdominal walls, the bowel walls rather, the different layers of the bowel walls. I'm trying to compress it to see whether it was squish or not, and it remains quite dilated. And here I'm trying to measure it, though I've undermeasured it this end, and it's greater than 0.5 centimeters. So this is a dilated target appendix, and I'm able to actually put it in longitudinal view as well, and we can see that elongated structure. And here is actually the fecal lift that's causing the obstruction itself. But very much a rule-in diagnosis for me for this. Again, sticking with children, the marker here is in the wrong place. This is a child, 6-year-old child, who presented with right upper abdominal pain and extremely painful. And you can imagine what the differential might be, and perhaps in my New Zealand setting most of all. And you can see there we've got some peristalsis in bowel. As I go on to look at the abdomen, I mean, look at this. Is this the kidney we're looking at? No, it looks like the cortex of the kidney, perhaps with the collecting system in the middle. But no, you've guessed it, I'm sure. This is intussusception. And this is more of a longitudinal view of the bowel. And we can see one part of the bowel here swallowing another part of the bowel. And on this view here, this is the kidney we can actually see here. And the intussusception is lying above that kidney. So this was very helpful because it made me decide that I didn't refer to my tertiary hospital, but I needed to actually go to a pediatric hospital setting. Now, commonly we might deal with abscesses, or we might think of peripheral abscesses, but every now and then we get an unusual one. This is a case of someone who presented to the rural hospital who'd had previous orthopedic surgery and had pelvic metalwork placed, and they came in with fever and lower abdominal pain. And this here is their pelvic brim, and this is an anechoic area here. And this is a collection which I've measured, and you can see there's a reasonable volume sitting there. And this is something I think, okay, well, I better refer this to the orthopedic surgeons, and they will need to be under anesthetic and have that drained. But I spoke with the orthopedic surgeon and said, well, it looks reasonably superficial. I think we can get hold of that and get to that locally. And here we are passing a needle into that abscess. And I'm able to drain some of that pus out. You can see me sucking it out there. The needle gets blocked. So I give it a bit of a flush to open it again. And we're able to remove virtually all that pus there, get them onto high-dose antibiotics, and then they didn't need to go on to their tertiary center. Obstetrics and pregnant women are a huge part of the value of POCUS. And just simple questions. Someone who's presenting in late pregnancy and perhaps in labor, which part is presenting? And we can learn pretty early enough. We know that we spoke about how easy it is to see fluid. Well, at the other end, we've got the dense cortex of bone, which is reflecting all our ultrasound. And we've got the cranium here of the baby. This is, of course, the head end. And here we've got, this is the uterus. And here we've got the cervix. So we know this is a head presenting. And just that simple thing can be very reassuring and determine as the best place that this child may be delivered. But we also get women who come in with lower abdominal pain and bleeding, and either they may be still pregnant or have had a pregnancy and have had a miscarriage. And this is someone here. So this is a young woman. We can see the bladder here, and we can see the uterus here. And in the center of the uterus, we've got this anechoic area here. And as I'm fanning through in transverse view as well, I can see there's still a little bit of fluid there. I can't see too much fluid outside the uterus. As I focus in on the uterus itself, there's a collection there. And indeed, it looks very heterogeneous. And they had a miscarriage, but they carried on bleeding and need to be referred to the gynae team to have evacuation of retained products. But perhaps our most important group we need to be mindful of are those who have ectopic pregnancies. And so we have a woman who comes in with a positive pregnancy test. This is the transverse view. This is the uterus here. We can see the uterine stripe here in the middle, and I can't see anything there, but my eye looks to one side and I see this cystic structure to one side. And when I focus in on that, I can see that there's a cystic anechoic structure, and indeed, there is the pregnancy within that. And so this is quite clearly an ectopic pregnancy that's taking place within the salpinx or the fallopian tube. And here I might go on then to do a fast scan. And I've got the liver here and I've got the kidney, and I don't have any free fluid here. I've got the tip of the liver, don't have any free fluid there. And when I look on the left-hand side, again, I've got the spleen and the kidney. I don't see too much there. But when I look higher up and I see the spleen here and I go on to look at the diaphragm, this is the first place you're going to see fluid collecting. So it's an ectopic pregnancy who's got bleeding into her abdomen, and they need to expeditely be referred to have surgery. And I saw a great number of these actually in my experience in the ED department in Malawi. So one of the commonest things, of course, that we will see is and learn about is the FAST scan. So this is one of our algorithmic scans where we're looking, so it's the focus assessment sonographically in relation to trauma. And you can see here, we're looking at the right upper quadrant. This is someone's liver, this is their kidney, this is Morrison's pouch, and we've got the anechoic area that's lying in that pouch as well as around the liver. This is someone who, we have lots of people who ride mountain bikes, and they fell off their bike and the handlebar went into the upper left quadrant, and they had a splenic rupture. And remember that we don't commonly see injuries to the actual organ itself, but we see the repercussion of those injuries and collection of fluid within the abdomen. And this is free fluid that's around below their spleen. And when I go down then to look at the pelvis and these old scans, these are quite a number of years old. Over this side, we get the symphysis pubis. This is a longitudinal view. That small area is the bladder, which is nearly empty. And we must remember that what's then further towards the head, outside of the bladder, this will be the free fluid that's collecting in the pelvis, and this is the bowel that's floating around in that. So one of the things that I really thought about quite a lot in the differences in settings is that there are many causes, particularly in sub-Saharan Africa, and I'm sure the case will be the same in many parts of the tropics, of patients who present with chronic illnesses, and a great number of reasons as to why they might have fluid in their abdomen, which may be ascites or blood. But renal disease, hepatic disease, congestive cardiac failure, extrapulmonary TB, malignancies, ruptured ovarian cysts, that will produce ascites or fluid in their abdomen. And so the differential is quite broad, and that makes it quite difficult to work out exactly what may be going on. I was very fortunate in Malawi to meet Tom Hellier, and we had a good discussion about his FASH exam, which he developed from, I guess, an extension of the FAST exam. He works in clinics associated with patients who have HIV and extrapulmonary TB in association with that. And so it's focus assessment sonographically with HIV and TB patients. And in the Gambia, again, with the butterfly probe, the sort of criteria that he would talk about is looking to see if someone had any pleural fluid, and whether your eye can get into this, it's a bit free flowing, but here is actually, this is in the chest, and occasionally we can see the diaphragm here, this is the liver, and we can see some free fluid up in the chest. This is another view of it. This is in the lung. There's some free fluid there. There's some fluid within the lung itself, producing some B lines. And we can see that this is the liver here, and we can see the diaphragm just here. But there's many differentials that may cause this. As I go on down to look into the abdomen, this is their liver here, this is their kidney, and I can see the ascites here. And we've also got some fibrin here, so there's a complicated ascites going on here. But the more distinctive things that would be really helpful, particularly with a positive FASH exam, is to look for the far more specific microabscesses in the spleen. So this is down looking over their spleen, and this is some free fluid ascites in the abdomen. But if you look at the spleen itself, you can see these hypoechoic rounded lesions that blink at you as they pass through. And you can see them here. This is just with the patient breathing, and you can see those flashings there, and those are microabscesses, and that's quite sort of specific and enough to be giving people treatment with those findings. And sorry for the brightness of the far field here, but this is down in their pelvis, and you can see the sort of the complex sort of effusions that they've got in their pelvis. And also that is more distinctive and more specific for those who have extrapulmonary TB. This is a transverse view, again using a butterfly of the abdomen. For those who recognize the appearance, this is the vertebra, this is the shadow you can see beyond the vertebra. This here is the aorta, this is the IVC, but we've got these other round lesions that are here that aren't vessels. And this is these are lymph nodes, and this is para-aortic lymph nodes we can see on the transverse view, and then on the longitudinal view as well. There are also some rounded lesions here, which I think also are para-aortic lymph nodes. And just a last case, I know I've gone on and been talking for a long time. This is another quite interesting patient from Malawi who is HIV, presented with abdominal discomfort, swelling, and weight loss. And this is a view of their spleen, and it's a big spleen. So there's the kidney below it, and it's a big spleen. But you can also see these hypoechoic areas in the spleen. They're not quite they don't look quite the same, maybe, as those microsplenic abscesses. I'm thinking, is this malignancy? What's going on? Then I have a look at the liver, and boy, you can see this liver is looking very different as well, with these hyperechoic, very bright areas in the liver. Thinking, what on earth is causing this? And as I scan around, they've got ascites as well. You can see that flashing there of the liver. And down in the pelvis, this is the bladder here. This is fluid that's outside the bladder and bowel floating there. So they've got a reasonable amount of ascites. And when we look at the liver close up, we've got these sort of those bright lights that we saw before. Is this the liver starry sky that is mentioned for acute infections of the liver? You go back and have a look at the spleen, and it looks now that maybe blinking a bit more. There may be some microabscesses there. I showed these to Tom Heller, and we weren't exactly sure how to fit it all together. They probably had extrapulmonary TB, but the differentials could be broader than that. So they could have different number of opportunistic infections. They could have malignancies. Maybe that liver, that's a pattern you certainly see with pneumocystis carinii as well, or pneumocystis urevecii. So the differential was broad. And this brings me to another point, and that's to say that you'll be ultrasounding, and if you're the only person in the place where you are, and this is the only form of imaging you have, you might, one, make the diagnosis. You may be suspicious of the diagnosis. You may not have the resources to refer them on. Indeed, if you make a diagnosis, You may not have the resources to confirm that with either the blood tests or going on for CT scans. You may not have the services to go and look at them. And indeed, you may find things that ultimately have no treatment within the country that you're in. And that makes this practice very challenging. So sorry for talking for so long, but I'll leave it there and leave it open for questions for me.